Good morning, all. On behalf of UN Mehta Institute of Cardiology, I welcome you all. Today, we will be discussing about coronary circulation. We all know how important coronary arteries are for our life and, of course, for our heart. We will be having brief view regarding the whole coronary circulation in this short lecture. Coronary circulation consists of arterial supply, venous drainage, and lymphatic drainage. Now, if we talk about the arterial supply, the cardiac muscle is supplied by two coronary arteries, the right and the left. Both arteries arises from the sinuses behind the cusps of aortic valves at the root of aorta. So here we can see that right from the root of the aorta on the right side we can see it the right coronary artery arises, and from the left cusp, the left coronary artery, we can call it also as a left main artery, which further divides into the left anterior descending artery, that is LAD, and circumflex artery. These all are the branches of the right coronary artery. We will discuss in detail in the next slide. The right coronary artery, it is smaller than the left coronary artery. Arises from the anterior coronary sinus, as we saw in the last picture. Here also it has been described exact the origin of the right coronary artery from the right cusp. It emerges from the surface of the heart between the pulmonary trunk and the right auricle. Winds round the inferior border to reach the diaphragmatic surface to reach the posterior interventricular groove. It terminates by anastomoting with the left coronary artery. Branches of the right coronary artery, larger branches and the small branches. Larger branches are marginal and posterior interventricular branches. The smaller branches are right atrial, infundibular, nodal and terminal branches. Here we can see the branches. Branches to the SA node, branches to the conus, conal branches, marginal, acute marginal branches, branches to the AV node, and terminal branches, that is PLV and PDA. Areas of distribution of the right coronary artery. It distributes mainly the right atrium, greater part of the right ventricle except the area adjoining the anterior interventricular groove, which is supplied by the opposite artery. A small part of the left ventricle adjoining the posterior interventricular groove. Posterior part of the interventricular septum, whole of the conducting system of the heart except a part of the left branch of AV bundle. The SA node is supplied by left coronary artery in 40% of the cases. Now we come to the left coronary artery. As we can see in the picture that it arises from the left cusp of the aorta. Immediately after arising, it divides into two main arteries. One is LAD and other one is LMCA, that is circumflex artery. It is larger than the right coronary artery. It arises from the left posterior aortic sinus. It runs forward and to the left and emerges between the pulmonary trunk and the left auricle. Here the anterior interventricular branch is given. The further continuation of the left coronary artery is sometimes called the circumflex artery. After giving off the anterior interventricular branch, it runs into the left anterior coronary sulcus. It winds around the left border and near posterior interventricular groove, it terminates by anastomoting to the right coronary artery. Larger branches and the smaller branches. The larger branches are anterior interventricular, branch to the diaphragmatic circuit of the left ventricle, and the smaller branches are left atrial, pulmonary and small terminal branches. Here in the picture we can see that LMCA, it gives off the LAD, which runs into the anterior interventricular groove, and another one is the circumflex branch, and the small branches as we discussed in the last slide. Areas of distribution. It distributes left atrium, And for the ventricle, the greater part of the left ventricle except the area adjoining the posterior interventricular groove, which is supplied by the right coronary artery. A small part of the right ventricle adjoining the anterior interventricular groove, anterior part of the interventricular septum, the part of the left branch of the AV bundle. Now we'll have a look about the collateral circulation, which is most important in coronary artery disease and also the patient who have survived the myocardial infarction. Now cardiac anastomosis, the two coronary arteries anastomose in the myocardium, the extracardiac anastomosis and the intracardiac anastomosis. The extracardiac anastomosis is the coronary arteries anastomose with the vasa vasorum of the aorta, vasa vasorum of the pulmonary artery, internal thoracic artery, bronchial artery and phrenic artery. This channel opens up in emergency when coronary arteries are blocked. Now we'll talk about the coronary artery dominance. Now what is the right dominant circulation and what is the left dominant circulation? So it all depends on the posterior interventricular artery. If it is supplied by the right coronary artery, then it is called the right dominant, and if it is supplied by or it arises from the circumflex artery, then it is called left dominant system. And if it is supplied by partially by the right as well as from the left, then it is called codominant circulation. Now functionally, the functional division of the coronary arteries are: large coronary artery, which is called the epicardial coronary arteries, lies on the epicardial surface, and it has the advantage that it conducts the blood with very little resistance. The small coronary arteries, it descends into the myocardium, and there are of two types: subepicardial vessels and subendocardial vessels. Small coronary arteries are the principal resistance vessel of the heart. Change in their diameter regulate the coronary blood flow. Now we'll talk about the venous drainage of the heart. As we can see in the picture that the venous drainage of the heart is by mainly three tributaries. Like one is the coronary sinus, which opens up into the right atrium, anterior cardiac veins and vena cava minimi. Now coronary sinus. This is the largest of the vein of the heart, situated in the left posterior coronary sulcus. It is about 3 cm long and ends by opening into the posterior wall of right atrium. Its tributaries are great cardiac vein, middle cardiac vein, small cardiac vein, posterior vein of left ventricle, oblique vein of left atrium, which is also called Marshall's vein, and the right marginal vein. Now, if we talk about great cardiac vein, it enters the left end of the coronary sinus. The middle cardiac vein, it accompanies the posterior interventricular artery and joins the right end of the coronary sinus. Small cardiac vein, it accompanies the right coronary artery and joins the right end of the coronary sinus. Posterior vein of left ventricle, it runs on the diaphragmatic surface of the left ventricle and ends in the middle of the coronary sinus. Oblique vein of left atrium, which is also called the Marshall's vein, it runs on the posterior surface of the left atrium, joins the left end of the coronary sinus and develops from the left common cardinal vein. The right marginal vein, it accompanies the marginal branch of the right coronary artery. Right coronary, yeah. Now anterior cardiac vein. 3 to 4 small veins run on the anterior wall of the right ventricle, opens directly into the right atrium. These are anterior cardiac veins. Now we also have vena cava minimi. It is also called the smallest cardiac veins or the Thebesian veins. There are numerous small veins present in all 4 chambers of the heart, which open directly into the cavities. The Thebesian venous network is considered an alternative, the secondary pathway of the venous drainage of the myocardium. It is named after the German anatomist Adam Christian Thebesius, who described them in 1708. Lymphatic drainage of the heart. Lymphatics of the heart accompany the coronary artery and form two trunks. The right trunk ends in brachiocephalic node and the left trunk into the tracheobronchial lymph node at the bifurcation of the trachea. Now, what are the peculiarities of coronary circulation? The main thing is that all the arteries of our body is mainly supplied in the systole, whereas the blood flow in coronary circulation is during the diastole of the cardiac cycle. Also, the coronary arteries are the end arteries. It has a high capillary density, it has a high O2 extraction capacity. Regulation is mainly by metabolites. Anastomosis is mainly anatomical, as we saw in the last slides. The coronary vessels are susceptible to degeneration and atherosclerosis that can lead to the coronary artery disease. There is evident regional distribution. The subendocardial myocardial layer in the left ventricle receives less blood due to more myocardial compression, but this is normally compensated during the diastole. However, this renders this area more liable to the ischemia and infarction. Now we'll talk about the coronary blood flow. Now, what is the normal coronary blood flow? So, in the resting situation, coronary blood flow is about 225 ml per minute, which is about 0.7 to 0.8 ml per gram of heart muscle, or 4 to 5% of the cardiac output, total cardiac output. In severe muscular exercise, the work of the heart increased and the coronary blood flow may increase up to 2 liters per minute. Now, which are the factors which regulates the coronary blood flow? The one is the physical exercise or the physical condition. Another one is the chemical, neural, hormonal or reflex. Now we'll talk about the physical factors. So it is mainly dependent on the aortic blood pressure. Coronary blood flow is directly proportional to aortic blood pressure, especially the diastolic aortic pressure. Most of the coronary blood flow occur during the diastole. When the diastolic pressure decreases, as for example in aortic incompetence or any valvular heart disease or any aortic regurgitation, when the mean arterial pressure is decreased, the coronary blood flow will automatically decrease. Blood flow to the endocardial region is more severely impaired than is that to the epicardial region of the ventricle. Now the another factor is heart rate. Excessive increase in heart rate, that is paroxysmal tachycardia, decreases diastolic period, decreases coronary filling, as it occurs mainly during the ventricular diastole, which will lead to the decreased coronary blood flow. So more the tachycardia is less the coronary blood flow. Another one is the cardiac output. Coronary blood flow is directly proportional to the cardiac output, that is increased cardiac output will increase coronary blood flow, decreased cardiac output will decrease the coronary blood flow. So in any cardiac patients in post-operative period, it is very important to maintain adequate cardiac output, to maintain adequate coronary blood flow, which will lead to normal myocardial perfusion and very good prognosis of the patient in the post-op period. Increased cardiac output will lead to increased blood pressure in aorta. That will lead to the reflex inhibition of vagal vasoconstriction tone, that is called Nerp's reflex, which will lead to coronary vasodilatation, which will lead to increase in coronary blood flow. Now, coronary blood flow mainly occurs during the diastole due to compression of the coronary blood vessel during systole by the contracted muscle fiber. Now during systole, what happens? Coronary blood flow is less than that during the diastole, with minimal blood flow during the isovolumic contraction phase. It is because due to compression of the coronary blood vessel with a low aortic pressure. What happens in diastolic phase? Coronary blood flow is more than that during the systole. with maximum blood flow during the isovolumic relaxation phase. Obviously, this is due to the dilated coronary blood vessels and high aortic pressures. Now, what are the chemical factors that regulates the coronary blood flow? The metabolic factors: increase in the cardiac metabolite, which lead to decreased oxygen tension, which can lead to the local hypoxia, increase CO2, increase potassium lactic acid adenosine in the cardiac muscle, which will lead to coronary vasodilatation and increase coronary blood flow. Now, lack of oxygen, that is hypoxia, is the most effective coronary vasodilator. It produces coronary vasodilatation through direct action on coronary blood vessel and release of chemical substance such as adenosine from ATP, which is a potent coronary vasodilator. So, in initial phase, due to hypoxia, will lead to coronary vasodilatation, but it will be beneficial up to certain limits only. After that, it will start deteriorating once the compensatory phase is over. Drugs like nitrates, aminophylline, caffeine, heline are coronary vasodilator, which increases coronary blood flow. Now, the nervous factors. There are mainly two effects. One is the direct effect and the other one is indirect effect. The direct effect, it is through the parasympathetic and sympathetic system. Now, vagus has a very slight distribution on the coronary, so its stimulation has slight dilatory effect, whereas the parasympathetic, which is through the alpha and beta receptors, exists in the coronary vessel. So, sympathetic stimulation will cause the slight direct coronary constriction. Now, the indirect effect plays a far more important role in normal control of the coronary blood flow than the direct. Sympathetic stimulation increases both heart rate and myocardial contractility, as well as its rate of metabolism, leading to dilatation of the coronary blood vessels. The blood flow increases proportional to metabolite need of the heart muscle. Now we'll talk about the hormonal factors: thyroxine and vasopressin. Thyroxine increases cardiac metabolism, which is a potent coronary vasodilator, which increases cerebral coronary blood flow. Now, vasopressin, which is an antidiuretic hormone, which causes coronary vasoconstriction and decrease coronary blood flow. Now we'll talk about reflex control. Enreps reflex. Increase in the venous return causes increased pressure in the right atrium, leading to reflex increase in the coronary blood flow, that is during muscular exercise. The another one is the gastrocoronary reflex. Distension of the stomach with heavy meal causes reflex vasoconstriction of the coronary blood vessel, which decreases coronary blood flow. Coronary autoregulation. If there is sudden change in aortic pressure, coronary vascular resistance will adjust itself proportionally within few seconds, so that a constant blood flow is maintained. The range of autoregulation is 60 to 40 mmHg. The mechanism is mainly through myogenic response. An increase in passive stretch caused by increased perfusion pressure causes active smooth muscle contraction. The another one is the chemical theory. Decrease in the perfusion pressure leads to increased adenosine and decreased oxygen, which causes vasodilatation and increased coronary blood flow. Endothelium derived relaxation factor, that is EDRF, is also responsible for the coronary blood flow. Hypoxia, ADP, VIP, muscular exercise, increased distension force stimulate the vasculature of the endothelium to secrete endothelium derived relaxation factor, that is EDRF, which is a potent vasodilator that causes coronary dilatation and increased coronary blood flow. So that is all we all saw about the coronary blood flow. If you have any questions, the lecture is open for discussion. Thank you.